Welcome everybody, my name is Dr. Gatsu. I'm a prosthodontist in Toronto, Canada. I'm an owner of specialty practice and prosthodontics limited to prosthodontics and cosmetic dentistry in Toronto. Today we're going to be talking about implant prosthetic complications. A lot of people ask me how do we deal with complications, and as you know, there's many types of complications ranging from surgery or prosthetic. We're going to be focusing on the prosthetic management of the most common complications reported. So the lecture is going to be broken up into kind of two halves. The first part is going to be about complications related to single or multiple teeth restorations. The second half of this will be full arch restorations. What I did was I looked at a systematic review done by Charles Goodacre, a prosthodontist out in the Loma Linda in the west coast of the United States. And back in 2003, they came out with an article that looked at the most common clinical complications related to implants and implant prostheses. Later on, they came out with another review that captured all the articles at 2001 and onwards. In that article, they kind of listed out all the complications that they see, and 8 out of the 15 complications reported were actually of prosthetic in nature, ranging from implant loss, overdenture fractures, resin veneer fractures, and so forth. So 8 out of 15 were prosthetic, and the rest were surgical complications. So in 2018, they came out with an article that looked at all the other articles from 2001 and 2017 that looked at prosthetic complications and pretty much summarized all the most common complications reported, ranging from multiple single teeth and then full arch. And then in full arch, we're going to break it down to removable prosthetics and fixed full arch prosthetics. We're going to go through one at a time, and I'll explain what the complications are and how we can solve these complications or minimize them from occurring. And then throughout, I'm going to show you some cases as to how these occurred and how I managed them. So the number one, by far, the most common issue related to single or multiple teeth implant restorations are aesthetic complications. So that means that generally implants are fine, there's no pain, there's no symptoms, it's purely an aesthetic. The patients don't like how they look. And that occurs on average around 10% of the time for single or multiple restorations. So here, this is a very common situation we see where there's just too much soft tissue. And so the implant may or may not be placed in the correct spot, but the main thing is there's too much soft tissue. If we look at this case here, there's a healing abutment on the right lateral position. And compared to the other side, there's at least 2-3 millimeters of additional soft tissue there, right? And so if we just restore the tooth as is, obviously it's not going to be very aesthetic. And so the position of the implant in a case like this is very, very important. If I told you that this healing abutment was only a 1 millimeter tall healing abutment and the implant is right there, it's a major problem. This is a problem that can't be fixed unless you remove the implant and replace it. If I told you that this healing abutment was a 4 millimeter long healing abutment and the implant is actually 4 millimeters higher, this is a very simple problem to correct. So in this case, we're able to achieve a pretty good result, and I'll show you how we got rid of the soft tissue. So fortunately in this case, the healing abutment, once we removed it, was a 3 to 4 millimeter long healing abutment, and the implant was actually placed deep enough where we can actually remove soft tissue and create a restoration that was going to match the contralateral side. So in this case, I took an implant level impression. We trimmed the soft tissue on the model to the ideal shape, the ideal zenith. Then we fabricated a provisional that was screw retained. We anesthetized the patient. Then we trimmed the soft tissue. And in this case, I used like a diamond, round diamond or egg-shaped diamond burr. And then we insert the provisional. And sometimes you may not have to trim. Maybe sometimes when the provisional is inserted, it just pushes and displaces the soft tissue. It depends on how much soft tissue there is. So we leave the provisional in there for 2 to 4 weeks, and we evaluate. Sometimes we may have to add and subtract to the provisional to tissue train to get the ideal contours. Once the soft tissue has sort of stabilized in the shape that we want, I would usually take a new impression and fabricate the final crown. right? In this case, it was a screw retainer. And so because the implant was placed deep enough, barely, we can see how the implant platform is pretty much similar at where the CEJ of the restoration was. So in this case, there is sort of like this emergence, which is almost like a 90 degrees. And so in this case, soft tissue health and long-term maintenance is important. We got to evaluate and make sure the patient can actually maintain this long-term. And in this case, it was. Now, in a case like this, where it's the opposite happening, where we have insufficient soft tissue, okay, it's a much harder problem to fix, and it's a much more common situation that we see, especially with single tooth implants. For this patient, the patient was missing the right central incisor around 10-15 years ago. An implant was placed and a crown was fabricated. We can see that the right central incisor, which is the implant restoration, has actually seemingly moved upwards apically, but in fact it's continued growth of the maxilla. In fact, all the other teeth in the jaw has grown down, and the area where there's an implant has stayed where it was. And so there's the issue of continued growth, and we try to really avoid putting implants in until people are aged, around 26, 27 years old or older. So compared to the left central incisor, we see that there is technically an insufficient soft tissue where the German margin is around 1 millimeter higher. Fortunately, in this particular case, once we remove the crown, there's actually some soft tissue underneath the crown, which we will able to tissue train and kind of push it back out towards the facial aspect of the ridge. We take it off, we see that the crown is shaped like this. And this is a perfect example of what a crown should not be contoured to. So, once in a while we see cases like this where there's a massive ridge lap on the buccal surface. And usually this occurs because the previous practitioner takes an impression. There was a healing abutment on that tooth, on that implant. They take an implant impression. The lab, wanting to make it an easy insertion, they don't really push or adjust the soft tissue on the model. And a temporary was never made to sort of tissue train. And the lab creates a restoration that can be inserted easily without really pushing the soft tissue, causing pain, but then created a ridge lap to get the ideal tooth height from the facial view. So obviously this is not something you should be doing, because long term this is very unhygienic. There's no way the patient can clean when it's ridge lap like this. But fortunately, after having this tooth in there for a good 10 years, but there is no significant bone loss. And the soft tissue, even though it's a little bit unhealthy looking, it was able to be brought back to decent health. So in this case, same process. We take an impression, we make an implant provisional that's shaped a little bit more hygienic. We insert that, and we let the soft tissue heal up a little bit. And hopefully the soft tissue in good health will creep in size a little bit. And from shaping the provisional a little bit less, more under contour in the cervical area, in the mid-facial aspect, we can promote the soft tissue from to kind of migrate incisally. So we see here, this is where I would adjust the, in this case, the acrylic, okay, because it's a provisional, on the mid-facial aspect, apical to the CEJ, where it's actually next to the soft tissue. If we remove some acrylic or material here, it's going to push the soft tissue a little less, and the soft tissue, when there's less pressure, it's going to fall incisally. And so here, after we adjust this, the soft tissue actually has migrated incisally a little bit to be more in line with the left central incisor. Now, if the soft tissue in the papilla region was inadequate, we would actually do the opposite. We would actually add more material to the interproximal areas to actually push and squeeze the papilla. And when there's pressure interproximally, it will actually squeeze the papilla incisally and get actually more soft tissue there, okay? So what you do to the mid-facial aspect and the interproximal aspect is actually opposite. So after a few weeks, the soft tissue is maturing. It's still a little bit redder than normal, but we can see that the soft tissue is actually kind of pretty even with the left central incisor. we can then progress to the final restoration. So in this case, the left central incisor was also very, very discolored. It was not endo-treated, but from the trauma, and the same trauma that took out this patient's right central incisor, the left central incisor had some trauma, and very commonly these traumatized teeth become darker over time, even though endodontically they're not necrotic. So the plan was to do a veneer on the left central incisor, and so there's another complication that can potentially arise, which is color matching. And that's a very common thing that we see with single anterior implant restorations is color matching. Difficulty in matching a single implant restoration to natural teeth, or matching it to other crowns, or having an adjacent dark tooth, which is what has happened here. Okay, so if we were to do a veneer on the left central incisor, we cut back initially 0.5 millimeter. And what we find is that the left central incisor gets darker and darker as you prep away the enamel, because internally the tooth is this color. And so if the tooth is getting darker and darker now, we need potentially more porcelain thickness to mask out this discoloration. So now, general rule is we need around 0.2 millimeters of porcelain thickness to make one shade change. So in this case, we can easily need in the realm of 0.6, 0.8 millimeters of porcelain thickness to mask this color. Okay, so the more we prep in, we're going to potentially lose more and more enamel, and we may get into dentin. So if we're getting to dentin and there's less enamel to bond to, we may now need to consider not just purely veneer, but more of like a 3/4 crown. We may involve the lingual aspect. So in this case, we actually do sort of a 3/4 crown, like a veneer, but actually wraps around half of the lingual as well, just to provide a little bit more retention form. Because based on the thickness we need for the porcelain to mask this tooth color, all the enamel will need to be prepped off. So the other complications, now we have one implant restoration, which is going to be zirconia in the middle with a screw access hole. So in this case, not only do we have the whole soft tissue complication, we also have a dilemma with color matching, because we have a right central incisor, which is going to be an implant restoration, which is, has a screw hole in the middle, right? There's a channel where the screw is going to go in. There's going to be a zirconia abutment or some kind of a substructure that can be in zirconia. And then on top, we have some sort of porcelain or something that we need to do to put on top of this to make it match all the natural teeth. On the other side, we have a single dark tooth, which is dentin and enamel. And we are now putting something that's not going to be so aggressive, but something that's kind of more conservative, like a veneer, but we can't do a full crown because we don't want to be so aggressive. So it's kind of like this 3/4 crown where the material of choice is either feldspathic or Emax or LESI or lithium disilicate, right? So we have different colors with different materials potentially. So one strategy we did here was to sort of neutralize the color, make the color the same using staining, pre-stained zirconia. Okay, so in this case, on the right central, which is going to be an implant, we then first create a screw-retained zirconia abutment or a substructure. The zirconia is first pre-stained to match the color of the prep on the left central incisor, so that at least the substructure is pretty much the same color. And then on top, we then create two veneers that get cemented onto the tooth and the implant restoration. So in this case, everything's still screw retained. This is to show you, like, once the zirconia abutment is inserted, the color of the prepped tooth on the left and the color of the abutment is very similar. And then two veneers, in this case was made with Emax, can be then bonded on top of the tooth on the left and on the implant zirconia abutment on the right. And just because it's bonded doesn't mean we have to do it in the mouth. We can actually, once we try it on with try and paste, we know what cement to use, what color cement to use. We obviously would unscrew the zirconia restoration. We bond the veneer extraorally in a dry environment. First, clean up the cement, polish things up, and then obviously insert it back in as a one piece, at that point, a one-piece screw-retained ceramic restoration. Okay, and then the veneer on the left central incisor is just bonded on with the same colored resin cement. And so this is a case where there's really two complications. One is the soft tissue issue. Fortunately, by tissue training, we were able to actually utilize what she had left to control the soft tissue architecture. And then we also, did sort of like a two-piece veneer / zirconia abutment pre-stained to neutralize the internal colors. So that's the final result, and that's the final smile. So here's another common situation that we see. Now this is for sure, again, an insufficient soft tissue complication, but now it is unilateral, which is the hardest to correct, okay? So patient had an accident, lost the left central incisor and the left lateral. This patient was at school in New York, saw a periodontist there, which then proceeded to do some grafting and place 2 implants. So the patient kind of already have an implant at the left central incisor and also another implant on the left lateral. So then came to see us wanting to restore the anterior segment and to just sort of discuss options. So right off the bat, these unilateral cases are more difficult, especially if you're missing 2 teeth, because the papilla between the central incisor and the lateral that's missing is gone forever. And it's extremely difficult or actually impossible to get the papilla between the left lateral and the central incisor to match the contralateral side. I would say that's surgically very difficult, if not impossible, to get it exactly like the other side. So in a case like this, we have basically 2 options, right? We do 2 restorations that are going to be a little bit longer, long contact points where the gum's just going to be missing, or we use pink porcelain. So papilla's gone, soft tissue architecture is just flat, okay? And even if we do provisional to try to tissue train, it's never going to look like the contralateral natural teeth side. So the first thing we do here is to see if the patient's going to be okay doing purely white ceramic restorations, meaning no pink porcelain, right? And we try to tissue train, as expected. No matter how you tissue train this, the papilla is not going to come back. Sometimes if there's a low smile line, and psychologically sometimes patients are okay with this, and you can then go ahead and create just implant crowns like this. I would say aesthetically, it's always nicer to do pink porcelain to replace the missing soft tissue, assuming that the pink porcelain can be done well and matched nicely. So in this case, the right central incisor and the left canine also needed restorations. Those are going to be crowns. And definitely the plan is to do pink porcelain here. And that's the sort of the last resort when there's insufficient soft tissue and grafting surgically, soft tissue can't be replaced. The last option is to do pink colored porcelain and match it as nice as we can. And so we had to take some nice shade photos. In this case, we have customized pink porcelain shade tabs that the lab that we work with provided for us. We take consistent, nice shade photos and we send it to the lab, and we get back porcelain ceramic restorations with pink porcelain to replace the missing papilla. So there's a few things that's not ideal here. If we were in day 1 when we planned this, I would definitely ask for only 1 implant to be placed at the left central incisor and no implant to be placed on the left lateral because of hygiene issues, right? It's much easier to floss and clean a single implant with a cantilever lateral than to clean splinted implant restorations. With the pink porcelain, we obviously want to have it with no ridge laps, so the underside of this is smooth and it is as convex as possible. But when there's implants side by side, you have the option of splinting or non-splinting. When we're doing pink porcelain to replace the papilla, to have them non-splinted is very, very difficult to make aesthetic, because if you were to split this pink papilla in half, it's always going to look like there's a slit in between, okay? No matter how you do the pink porcelain, how precise things are, it's very difficult. So the entire pink porcelain papilla needs to be one piece, and if there's 2 implants side by side, you sort of aesthetically have to sort of splint them together and teach your patient how to kind of keep this clean long term. So we did 2 additional crowns on the adjacent teeth. Okay, so once it's in like that, and in the smile, when the lip is there, when there's some saliva in there, And once it's in, after a few weeks, the soft tissue sort of kind of usually migrates down a little bit. It's usually not that noticeable. Look very closely, you can kind of tell, but unfortunately in this patient, they have a sort of a medium smile line. It's not that noticeable. Okay. And so that's the before and after result. So if we were able to control this from day one, we would definitely have suggested that maybe the grafting is not necessary, because sometimes if the grafting is attempted and you get something, right, but it's not enough and you still need pink porcelain, sometimes the aesthetic result is actually worse, because what we have done is basically move the soft tissue, or the transition zone between soft tissue and pink porcelain, into an area where the lip's not going to cover it, right? So there's a big defect where the grafting is not going to sufficiently bulk up the soft tissue where we don't need pink porcelain. I would argue that, you know, the better solution is just a straight up not bone graft, or not soft tissue graft, or bone graft, and actually put the implants higher up so that the transition zone between soft tissue, real soft tissue, and pink porcelain is above the lip, right? So therefore the lip hides to that zone. If the plans for pink porcelain, okay, the implant should be at the deepest part of the defect for proper emergence profile. Okay, so if the implant is placed too incisally and the defect goes apically, then the porcelain needs to go apical to the implant platform. That's basically a ridge lap, right? So if pink porcelain is planned, the implant should be deeper than, you know, at the deepest part of the defect. Also keep in mind that the defect may not just be a vertical issue, it could also be a horizontal issue. Sometimes the bone resorbs in and you need to actually get pink porcelain to bulk out and help support the lip. That's also needs to be taken into consideration. So if there needs to be pink porcelain on this aspect, the implant also has to be deeper to when the pink porcelain starts. Generally, less implants the better for pink porcelain situations, because less implants, it's easier to clean. Cantilevers, if this was a one tooth implant at the central and the Pontic was the lateral, it's very easy, super hygienic, because the patient just floss between the lateral incisor and the canine and kind of run the floss underneath it. Splinting it makes it harder to clean. And also, pink shade communication is very, very important and difficult. It's a collaboration between the ceramist and the dentist. Really good shade photos needs to be taken, and the ceramist also needs to be skilled enough to create the pink porcelain to match real soft tissue. And it's actually very, very difficult. A lot of ceramists are very good at matching white ceramics to teeth, but matching pink porcelain to soft tissue is a little bit more difficult, okay, I think. So here's an example of a single tooth implant restoration with a cantilever. Is a lot easier to clean. So another complication is positional problems. So you know, I showed this picture to people I've lectured to, and I asked people, like, is this a good implant position? Is this good placement, right? And so if we look at this view, a lot of people will raise their hand and say, yeah, this is a good placement. If I show you people this view, usually in the room, you know, some hands come down, but still a good number of people will say, yeah, this is a pretty good position, because it's dead center in the middle. It's in the middle, on the occlusal view is in the middle. This is kind of in the middle, mesologically on that space. If I show you this restoration, again, most people say, okay, yeah, like it looks okay. There's nothing wrong with it. But if I show you this view, we can see that there's a very big problem here. In order to get the tooth to look at the proper height, the height of tooth, the porcelain needs to be extended beyond or apically to the implant platform. And obviously this is a no-no. You should not put something like this into the mouth, because it's unhygienic and likely you're going to get soft tissue or bone issues long term. So the reason here this occurs is because the implant is not placed apically, ideally. And so in terms of the 4 dimensions of where the implant can be placed, mesodistally, usually people get that fairly decent. Buccolingually, most people kind of focus on that the most, you know, making sure that it can be screw retained or being that. So I think most people know where to put it buccolingually. The angle of it is also commonly usually not a problem. People are very surgeons are very aware as to, you know, the angulation. But kind of what I see as the biggest problem, and actually the most important problem, the most important dimension or position, is the apical incisal position, the vertical height of the position. I can tell you that's the most important prosthodontically because that's the one thing that there is no fixed prosthetic. If the angulation is not ideal, or buccolingual is not ideal, or mesodistal is not ideal, there's a lot of prosthetic complications with like ankle screw channel abutments, custom abutments, making them screw retained. There's a lot of options to sort of fix the situation. But if the implant is placed apically or incisally not ideally, there is no fix. So in this case, the implant is placed too occlusally, not deep enough. So if the ideal CEJ is here, the implant needs to be more apically. How much? Generally 2 to 3 or 2 to 4 millimeters. Generally, prosthetically, the bigger the discrepancy between the implant size and the tooth size, the deeper you need more running room to have it properly emerge for emergence profile. So if there's like a big tooth and a big implant, maybe you don't have to put it deep enough for emergence profile, right? But if it's a big tooth and a small implant, you need more vertical running room to get a better emergence profile. And this is especially important in the anterior zone where the height of the final restoration is crucial, right? So if you're doing a central incisor where that tooth needs to be, for example, 11 millimeters tall, the implant position needs to allow for that. If the implant is placed too incisally, you're forced to create a shorter tooth, and sometimes that's clinically unacceptable for the patient. So in this case, the implant needs to be 2-3 millimeters deeper. If the implant is placed a little too incisal, and it's sort of level where the CEJ is going to be, it's going to look something similar to kind of the first case I showed you where the emergence is kind of like this 90 degrees jetting out here. Maybe a soft tissue hygiene issue. And this most recent case is in a situation where the implant is placed actually even more incisal to the ideal CEJ position. In this case, you get a ridge lap because that's a no-no. You need to then adjust the porcelain higher up and the tooth is going to look shorter. It may not be a problem for posterior areas, but I would say the biggest problem is in the upper first premolar region where people are not paying as much attention, thinking it's a posterior tooth, but the first premolar is very, very much in the aesthetic zone. And so you may ask, why would an implant be placed too incisally? That can commonly occur if, let's say, the lower tooth has been missing and the upper tooth has erupted down and brought the soft tissue and the bone with it. Whoever's doing the implant takes out the tooth, puts the implant bone level, and then restores the tooth, top and bottom now, and now that implant is actually too incisal. In fact, those cases where the soft tissue, the bone, the implant needs to be actually placed deeper, and potentially some bone needs to be contoured. So that's sort of aesthetics. Those are some of the more common complications that we see. Too much soft tissue, insufficient soft tissue, and the color issues.